Good afternoon, everyone. Uh, Thanks for giving opportunity for Mindray. So I will be talking about two uncommon interferences in biochemistry, which we come across mainly in hospital settings. So there was a 68-year-old female who was regular on health checkups for last 4 years. Everything is unremarkable. She came to OPD with jaundice, and she has been admitted for further workup. This was the LFT report. If you see, if it is more of a obstructive jaundice picture with increased total bilirubin and increased direct bilirubin. And the protein was pretty low because of low albumin. And we went further tests. There was a surprise, cholesterol being 1002. And last year health checkup and all, cholesterol was unremarkable, normal. Triglycerides were also just borderline. So, and this was the electrolytes picture in this patient, sodium being 123 and chloride being 93. So I immediately called up the doctor and informed not to do sodium correction. Why? Sorry? ICTRES won't affect electrolytes much. And after I asked to stop sodium correction, and I immediately advised to do ABG on the spot. Yes. So when ABG sodium was checked, it was 140, and this is the case of pseudo-hyponatremia. So I'll be going through how exactly this pseudo-hyponatremia occurs. To understand that, we have to understand what exactly the components we measure during electrolytes measurement and what exactly the calculation happens later. So if you take a serum, there will be serum water content, what we call as SFCC, and serum solid content, SSC, which will be around 7% and 93%, which is the constant. When there is increased serum solid content, issue status. What we see on the reports is serum sodium, but what we measure is serum water sodium. We measure only sodium in this component. We calculate and further extrapolate and report it as serum sodium, what we see in daily reports. So what is the relationship? Serum water sodium is serum sodium divided by serum water content, or you can multiply the other way around. So when you call it as pseudo-hyperkalemia, when sodium serum water is normal, but what you see in the report, that sodium serum is low, then you call it as pseudo-hyponatremia. So to understand that, there are three factors which commonly affects why it's generally seen only in indirect ISE, but not in direct ISE. There are three factors. Most important factor being dilution effect. To understand that, I will show a small calculation, how exactly the calculation happens behind the instrument or in the instrument. So this is a serum sodium for what you see in normal 140 report. Sodium serum would be close to 151. What you see is sodium serum water, it will be 140. So I'm taking base sodium as 151. And I'm taking three scenarios, solid content, one being 7%, 14%, and 21%. So based on extraction, we'll have the serum water content. And this is the amount of serum that the equipment would aspirate. Generally, it will be 10 microliters. And how much would be the serum sample water? It would be water content, that is 0.93 into 0.01. Same applies for all the columns. And you add dilution. Most of the dilutions will be from 22 to 34 range, depending upon the manufacturer. I am taking 30 as the dilution factor. So in the instrument, to the 0.01 liter serum, you will be adding 0.3 liter diluent. So by this, the total sample water will be this, that is serum water plus diluent, total volume. So what will be the dilution factor? In first case, the dilution factor is 33.2. In second case, it was 35.8. In third case, it is 38.9. So now the electrode would measure the electrolyte. So it comes like this, because based on serum water content, what you get the sodium values. So you multiply by 151. Now you measure total sodium. Then you come to the calculation. What the system does now, it will divide using the dilution factor. In first case, it divides, it is a normal solid content, so it will use a 33.2 factor. So value will come to 151. But in second case and third case, the instrument is prefixed for 7% only. It won't use the different dilution factor. It will use the same first dilution factor in all the calculations. Same 33 point. The 151 became 140 in second case and 128.9 in third case. The calculation doesn't stop here. What we report is sodium serum, not serum water. So there is one more calculation, that factor 0.93. This is also constant in 3 scenarios because these do dilution factor and 0.93 is prefixed in the system. So in first case, where the solid content was normal 7%, you get normal sodium 140, whereas 14% solid content, the sodium would be reflecting 130, whereas in third case, where the 21% of solid content, what you measure will be 120. This shows pseudo-hyponatremia because of dilution factor effect happens in indirect ISC. It is not seen in direct ISC because there is no dilution at all in direct ISC. There are other 2 factors, hyperviscosity effect, majorly seen in multiple myeloma patients where aspiration itself, so there will be low aspiration of serum, so dilution will be more, but you are using dilution consistent factor, so again the calculation will go wrong. So you will have abnormal value again. And electrolyte exclusion effect, which you don't see nowadays because it is only seen in flame emission spectrometry. So coming to summary, when you should look for pseudo-hyponatremia? One, when the protein is more than 10 grams. Second, when TG is more than 3,000. And when cholesterol is more than 1,000. And how to identify? There is discrepancy between lab report if lab is using indirect ISC and ABG. And there is high osmolar gap between measured and calculated. And there is discrepancy between measured LDL and calculated LDL, because I'll coming to that why it will happen. So 3 mechanisms I already explained. One is dilution effect, the second one is hyperviscosity effect, the third one is electrolyte exclusion effect. And there is one more thing in this case, why the cholesterol is 1,000. So this was a case of bile duct carcinoma, obstructive bile duct carcinoma. In case of obstructive bile duct carcinoma, because of the blockage of flow of bile, there is an abnormal lipoprotein metabolism, which gives rise to abnormal lipoprotein called LPX, sometimes LPY also. This is falsely giving high value of cholesterol. Some, in few equipments, depending on the method, it will even give high value of direct LDL also sometimes. It's very important to identify LPX. It could be identified only with electrophoresis, lipoprotein electrophoresis, which is rarely available. Best way is if you are seeing generally cholesterol more than 1,000 without any genetic this thing, then it's most probably because of LPX. The obstruction should be relieved immediately because it is highly atherogenic. It is noted that within 28 days it could cause a plaque rupture and cause a MI. There is something pseudo-normonatremia, which is associated with hyperglycemia. It doesn't generally cause pseudo-hyponatremia, where there also you have to stop sodium correction. So which laboratory technique? I went and saw how many people use direct ISC and indirect ISC. There was a very good systematic review where people have checked what technique is being used in hospital and everything. So they took 361 articles and they had only information in 177 articles, where 126 were indirect, 25 were direct, and 19 were both, and 2 were flum. And remaining 50% article didn't have information. Why I'm highlighting is, we all will be publishing. I want you to highlight that you should kindly mention the method. Otherwise, clinician will be discussing with one method paper and you will be releasing the report in the other method, so that it can be confusion. And surprisingly, all these 361 articles were related to hyponatremia only. Only 177 articles had the methodology. The other half of the articles didn't have the methodology. So coming to second case, sorry for the pic. This was the WhatsApp pic sent by my nephrologist. That was the report released by me, and this was the ABG report. Potassium. Done within 10 to 15 minutes difference. So I repeated the test with fresh serum samples. Still the serum sample potassium was 6.48, but ABG value was still giving 3.5 even with the repeat sample. So we went and looked. It's a case of pseudo-hyperkalemia. Patient had platelets of 30 lakhs. So potassium was leaking. By the time sample reaches and you centrifuge, potassium leaked into serum, and it was giving high value, whereas in ABG, you don't centrifuge, and it was immediate. So the value was coming normal. So when you will label, before labeling pseudo-hyperkalemia, you have to rule out pre-analytical errors. Without ruling out pre-analytical errors, you can't put into pseudo-hyperkalemia, like prolonged tourniquet time, squeezing, heat contamination, delayed transport, or excess centrifuge, and hemolysis. So when to look for pseudo-hyperkalemia? Most common causes are thrombocytosis and leukocytosis. Thrombocytosis, about 20 lakhs of platelets, you can see this. And in leukocytosis, above 50,000, you will be seeing this. And there are two rare genetic disorders. One is familial pseudo-hyperkalemia, as the name suggests. And the other one is dehydrated hereditary stomatocytosis, where the leaky potassium happens from the membrane. Solution, one option was, in my case, we did a POCT there itself, and the potassium we asked to continuously follow up, because until the platelet comes down, I can't give the potassium value. Or you can use plasma heparin samples, lithium heparin specific. It may help, which will have shorter centrifuge time. You bring it immediately, centrifuge only for 3 to 5 minutes, and report it on plasma, saying difference with the serum. There is a difference in reference range for serum and plasma. Just put a note on that, and you can do still if you have a POCT facility. Thank you.
So, Dr. Prajwal, thank you so much. I just want to ask if you can throw some light on what happened when you gave this report of pseudo-hyperkalemia. Clinician sent you that ABG report on. So, how much time it takes for the clinician? Because that is also very, very critical. So, how did you handle this?
So actually what happened with this case, I released the report, and I was walking along with my hematopathologist. He also got the call. I also got the call from the same nephrologist saying he has released higher platelet count. I have released potassium difference. That's how I got to know the platelet, because I am with him for the breakfast.
Okay.
So we could able to solve very fast. As soon as I heard 30 lakhs platelet, I knew the answer. I sent a Barricard tube to get the sample. It was showing only 3.
So thanks to the breakfast. Actually.
Yeah.
And one more question is about the sodium.
Yes.
Now, if there was no lipid profile with that case, and just like say a electrolyte sample comes to me without a lipid profile, and I get this, then
It would generally we see for HIL indices, lipemia would have picked.
would have picked.
He would
But
have
then,
picked.
I mean, it can be missed. I mean,
It
so
can be, because triglycerides never directly
Yes.
proportional to turbidity.
Yeah.
It may be missed, definitely.
Yeah, I think it's a super, I think the moral is, yes, luckily you were with the clinician, and most of us should also know high platelets can cause this. If
Yes.
ignorance is bliss, then you would have missed it. Yeah. That's fantastic. I think we should, get this spread more on our platform also. We will try to, ask you to come on our webinars also, so
Sure.
that most of people who are attending, it would really be beneficial for people who are functioning in hospital-based labs, particularly because it's both bilateral. It's on fire also, but there is beneficiary, like you can immediately get histories and other
Yes.
reports also. Thank you so much. Thank you. Any other questions?
So no more questions, it seems. May I request Dr. Aparna to hand over the certificate to Dr. Prajwal, please? वही देखना है डॉक्टर बरनाली क्या बोल रही है